Dr. Nesse's main mission is to establish evolutionary biology as a basic science for medicine worldwide. So with that, please help me welcome Randy Nesse.
So I think Todd and Virgil have done a wonderful thing bringing us all together here. And for me, it's a special pleasure to come home, or at least close to home, after a long time in too much sunshine. I also think meetings like this are intellectually important because we've all had our different pathways and bring together different threads of knowledge that are all related to this topic, and none of us know all of it. And by the time we're done, I think we'll all have new ideas. I'm especially looking forward to hearing what other people are working on, because you can't keep up with everything everybody writes. You've got to come talk with them in person to see what's actually going on. I'd also like to emphasize before I go another step, however, that although mostly what we're going to be talking about is knowledge and theory, I've actually practiced psychiatry for 40 years and trained all the residents at the University of Michigan for a period of 7 years. And you know, while knowledge is helpful, it's not as good as skill. You actually have to do it and see patients and learn how to talk and learn how to listen and learn how to make good decisions on that part. And no matter what knowledge you have, it doesn't do that much good unless you have the skills that go with it. So part of what I'm going to be saying tonight is really a view from the trenches, from the clinic. But I'm also going to tell you a bit about how I came to have this peculiar interest and peculiar direction. The big message here is, hey, I've tried it both ways. I tried practicing psychiatry for 20 years, not knowing much about evolution, and I practiced it for 20 years knowing a lot about evolution, and let me tell you, it's better knowing things. A lot. Next theme is that our poor field of psychiatry and clinical psychology, especially psychiatry, it's ailing. Anybody who's followed the debate about diagnosis and recognized that many of the smartest people in the entire world formed 5 or 6 or 7 different committees that worked for years to all try to agree on the new diagnostic standards. And where's Jerry? He's back in the corner. He tried to help. He offered logic and data, which had no impact whatsoever. The big change there was that they decided that instead of depression not being an acceptable diagnosis within a little while of losing a loved one because it was confused with grief, they decided to eliminate that. I mean, it's really a very peculiar field, and it's very embarrassing, actually, often to be a psychiatrist. And frankly, I have, to some degree, for the last 15 years, kind of minimized my role as a psychiatrist because I want to be taken seriously as an evolutionary doctor. But now I finally can come full circle and tell you more about why I think evolution is so important for psychiatry. This is also a bit personal for me because my interest in all of this started in a suburban community of Detroit, which I won't name. It's Southfield, actually, where I grew up, and I thought that there must be something in the water. We were all on wells. And most of the people, or many of the people who, we liked them all, but many of them were very odd. There was the one guy who just was convinced that Shakespeare hadn't been written by Shakespeare. And there are other people who believe that, but not many people completely devote their lives to that and nothing else. Some of my favorite people loved to read books, and their entire house was covered with paperbacks. And it was only later that we learned that those paperbacks were read while drinking bourbon. And it was a very serious problem, actually. And their daughter, got in very, very serious trouble as a result of all of that. And then just the house over the way, is this a mental disorder? The guy goes to work every day, working in a car company, and the wife stays home. And eventually they learn that she actually has been going out days to people's houses with a pillow sack and stealing all their silver. She was a cat burglar. She had enough money, but what she did is go burgle silver from all the houses all around. Is that a mental disorder? It's odd. And then there were our close friends who were Holocaust survivors and started telling us little bits about what that was like and never going beyond that, except for sometimes when they got very, very upset and talked about what was going on around our community as it transitioned from a mostly Protestant farming community to a mostly Jewish community. These are very personal, intense kinds of things that were going on there. And I decided I wanted to try to figure out why on earth are so many people so screwed up, and could I do anything about it? And that was a young man's fantasy, right? I thought maybe if you just gave people a good talking to, and logic might help. I think a lot of people start off their clinical careers thinking that logic might actually be helpful. But then I had another peculiar and wonderful experience. When I was an undergraduate, I had this special privilege of being paid the huge sum of $400 a month to live at Mendocino State Mental Hospital in California and observe. This was a life-changing experience for me. I was on a ward where the patients had all been there 3 years or longer. They were trying to transition them into the community. Ronald Reagan was in charge, and not of the hospital, of the whole state. and so it was our job to help these people get into the community, and I had the experience of going to the local gas station with people who had schizophrenia and trying to help them pass as normal by buying a package of gum. And that taught me just how subtle the judgments we all make about each other are. You don't have to be off very far for people to say, ooh. It's a very, very subtle social dance we all do with everyone to present ourselves in everyday life. So that pretty much ruined me for having a proper identity as a mental health professional. And then if that wasn't bad enough, after I finished my residency at University of Michigan, I took a job in a medical clinic. So I was a psychiatrist in the medical clinic. I saw all the medical patients, most of whom either said they would never see a psychiatrist, and then I came in, at the end of their visit, or that they tried 2 of them, and the one wouldn't listen to them at all, just wanted them to talk, and the other started giving them drugs without any. So I really got this outsider's view of my profession. And again, it really ruined me. I was never able to say, I am a psychiatrist, it's the greatest, we do great stuff. I'm sorry, but I really saw it from the outside, from the patient's point of view, living in a mental hospital for a summer, and from the doctor's point of view, who saw patients who wouldn't go to a psychiatrist. It was a pretty bleak kind of thing. About that time, I started running a residency, and I had the greatest time. I thought the residents were just doing it because they're intellectually interested, but we had a seminar at 7 a.m. every Thursday morning to read Dick Nisbet's book about social psychology and strategies and shortcomings of human social judgment. It was the early version of biases and heuristics. And they all wrote a paper for me about something that all psychiatrists believed at one time that turned out to be false, and the psychological reasons why everybody would believe something that was false, such as drilling holes in the temples would let out the demons, or insulin coma therapy could help schizophrenia, or there were all kinds of things everybody believed. So by this time, I was finished with my training. I joined the faculty. I'd helped to do a lot of research on neuroendocrinology of anxiety, and I was frustrated, so I started hanging around the museum. And it was my incredible good fortune to be welcomed. And I thought these were just like regular good guy biologists, like Dick Alexander, Bill Hamilton, George Williams, Bobby Lowe, and Elizabeth Hill was part of this gang as well. We happened to be in the midst of the world's greatest evolutionary biologists on the cutting edge of applying evolution to human behavior. Before we knew it, David Buss showed up and started setting us straight about proper psychology, which none of us had really done before. Warren Holmes was there, Richard Wrangham was there, Barb Sputz was there. It was the most exciting group I think any of us has ever been a part of. My goal in life now, by the way, is to set up something at least half as exciting in Arizona. And we're on our way, but it's a very hard thing to match. Next comes, I'm telling you all about why I'm not suited for this task. So next I'd like to tell you about all my early research projects. And again, they ruined me. My first project was one where I drew blood every 20 minutes while we were treating phobias and causing people intense anxiety. And it worked great treating their phobias. But how many of them had increases in their cortisol levels like they were supposed to, because it was really big stress? Oh, about half of them. And sometimes they had an increase one session, not the next session. I could make no sense of this. I eventually decided to get out of it. It didn't seem like there was any rhyme or reason to who had a response. My next project looked at whether the beta receptors in the adrenergic system for anxiety patients might be hypersensitive, and that might explain why some of them had these huge reactions when we put them on antidepressants, where their heart pounded and they couldn't sleep and all that kind of thing. It was a good idea, and when we did the project by injecting isoproterenol and measuring the heart rate increases, we found out that their beta receptors were less sensitive than other people's. Oh, well, you do science, and it comes out the other way, and there was a good reason for that. My next project was trying to show that males were going to be better at recognizing family resemblances between parents and offspring than mothers, because mothers actually always know who their babies are, right? And fathers, it's always a bit of a matter of opinion. So a guy who has a superior ability to do that should have a selective advantage, right? Non-obvious, most people thought that women should do this better. And indeed, after a very careful study, I found that there was no difference whatsoever. It was a good try, good experiment. Now, my next project was to see if anxiety patients might have more accurate views of the world. That was when Taylor and Brown were doing their groundbreaking work showing that patients who had depression actually did have more accurate views of the world, or at least of their own abilities. There are challenges to that work and it's subtle, but I thought, hey, maybe why my anxiety patients are so scared of everything is because they just know how dangerous the world is. And the rest of us, are pretending to ourselves that it's not quite that bad. So I did a very big study of that and asked a lot of people on the diag in the middle of the art fair. It's not the ideal control sample, but it was pretty good. And a whole bunch of patients in our anxiety clinic to estimate the risks of all kinds of things happening to them. It was exactly the same. The problem with people with anxiety disorders is not that they think the world is more dangerous than it is. The problem is that they have a greater reaction to their perceived. And that's changed how I did my therapy with patients. I quit trying to tell them how safe the world was, and I started going full bore with behavior therapy. And the last one was the largest one and the most moving and difficult for me. I wanted to figure out why depression exists, and I thought the best model might be grief. And I went into my director's office when I started at the Institute for Social Research, and he said, "What do you want to do?" I said, "Well, it's impossible, but what I'd really like to do is find a whole group of people who have lost a loved one and look at those people who do not have a grief reaction and find out what goes wrong in their lives. Because I believe grief is useful, and the people who do not have any grief actually might have problems in life of one sort or another." And he got this little sly look on his face. And he said, "What would you say, Randy, if I told you that a prospective study of 4,000 people was conducted here, and they measured prospectively 8 hours of interviews and all kinds of biological things on these thousands of couples before anybody died, and then they studied them again 6 months, 18 months, and 48 months after the loss?" And I remember what I said to him. I said, "Oh, shit." So that I spent the next 3 or 4 years of my life getting big grants and hiring statisticians and analyzing this large database because the people who created it weren't there anymore. And here again, it turned out to be more complicated than I thought. I had looked, and we did find a lot of people who didn't experience much grief, and it turned out they were pretty much okay. We also found that there was vast variation in people's responses to loss, and gradually I was getting the idea that if you really believe in evolutionary theory and genetic variation, you shouldn't expect there to be one human nature, because there's different genetic variants that cause different personality characteristics that might all have relatively similar fitness. And great variations might be exactly what we should expect in these things. I also started looking at the detailed comments from individuals in this study, and it was very peculiar. Some of them who said at 18 months, "No, I never experienced any grief whatsoever. It didn't bother me." At 6 months, reported not eating, not sleeping, terrible grief, and all the rest. Whoa. Psychodynamics is true, folks. It's just, that was wildly. And then people went the other way as well. Some people who said that they had reported nothing at 6 months, at 18 months reported intense problems back. And again, I'm starting to grasp the idea that people are vastly subjective, they're not all that rational, and this is probably the way we're meant to be. So have I convinced you that I am not an accurate representative of any particular profession and the like? This is very peculiar, but I think it's put me in a good position to pursue an evolutionary approach to disease in general. Because while I convinced many of the residents when I was running the residency that an evolutionary foundation was crucial for understanding human psychopathology, it was quite clear to me that I was making no progress at all unless I had at least 20 or 50 hours with somebody. I gave talks to the American Association of Directors of Psychiatry Residency Training saying, "Don't you think we should teach behavioral ecology?" And the answer I got was very consistent. What's behavioral ecology? The people have no idea. There was no idea about kin selection, and when I started talking about more interesting and subtle things, such as maternal and paternal competition in the genome and things like that, people are just lost. They don't have the background to even appreciate that. So I realized there was nothing going to happen unless evolutionary medicine got to be respectable, and we some approach to disease in general. So it's been quite a detour, and a productive one, I think, to try to understand disease in general from the viewpoint of evolution medicine. I did bring these slides for a reason, I think. Let's see. What do we actually have to offer, though, after all of this slightly negative beginning? My theme is that evolution is a basic science. It's essential for us who are trying to figure out psychopathology and treat it. And especially it offers, I think, for behavior what pathology, what physiology offers for the rest of medicine. If you study pathophysiology and the mechanisms of disease, you've got to first understand how regular old physiology works. If you're going to understand abnormal behavior, you first better understand how normal behavior works, and not just the neural mechanisms, and not just the psychodynamics, and not just the learning theory, not just the social theory. You need to understand the mechanisms that were shaped by natural selection and how they shape behavior. You need especially to know why there are emotions before you can study emotional disorders, how relationships work before you can deal with relationship problems. You need to figure out why the psychiatric diagnosis system is so pathetically confused. And you need to come up with new research ideas, thanks to your evolutionary perspective. You'll notice the part that I hope some of you will feel free to argue with me about. I don't think there should be any such thing as evolutionary psychiatry. As soon as you say that, people are going to start doing evolutionary psychiatry therapy. And it's going to just be a debacle. People are going to do things without evidence. They're going to be very popular and get in the New York Times. And then other people are going to say the whole field is nonsense, evolution is nonsense. I wish there weren't any such thing as evolutionary medicine, frankly. Some of us have tried very hard to say our journal is evolution, medicine, and public health. It's three fields. We're trying to put them together. It's too late for that. And everybody says, how do you do evolutionary medicine? Is that a special kind of medicine? No, it's just using the basic science of evolutionary biology for medicine. But I have to explain that over and over and over again. I hope we can spare ourselves that for this field. And also, everybody really wants quick fixes. Martin and I are co-authors on a paper we're trying to get the Lancet to take about evolution and mental disorders, especially for public health. And the editor said, this is interesting, but we don't see how this is going to improve what clinicians do in a clinic tomorrow. And we say, well, gosh, doctors learn calculus and quantum mechanics and embryology, and we insist that they learn these kinds of things. Do you want to see how those apply in the clinic tomorrow? They were not amused. They said, our readers, our clinicians, they want practical things. And this brings me back to the perspective of a clinician. There are a few of us here who see patients, but only a few. And I wish in the next meeting like this, I hope it'll be half clinicians. They really are facing real specific problems with specific people every day, and I got to figure out what to do. And understanding, I think, helps, but it is no panacea. The burden of mental diseases is absolutely unbelievable. You probably read in the New York Times version, but unipolar depression accounts for 1/3 of lost daily lives, lost daily years. 1/3 for women of reproductive ages in developed societies. This includes all medical disorders, not just mental disorders. The second most common is schizophrenia. The third contributor is bipolar disorder. Fourth is traffic accidents, most of which are related to alcohol use. Then there's obsessive compulsive disorder. Notice you've already used up 2/3 of your overall medical morbidity with mental health problems before you ever get to osteoarthritis. And after that, you get to chlamydia, sexually transmitted, and self-injury. Breast cancer, no, bad things, way, way tiny, tiny, tiny. I mean, when I show this for psychiatrists, I say we really should demand 2/3 of the research budget for the country. But the fact that all of these things can be going on without much serious understanding of how behavior is shaped by natural selection in the first place is just shameful. And it's just outrageous. But the people who are running the research funds appropriately say, hey, show us how it's useful. We got patients who need help. We're trying to get help for them right away. Another thing that's peculiar about mental disorders we should be aware of is they occur mostly at the time in life when everything else is at its most healthy. The only other problems similar are childbirth-related problems. Why is that? That's a big clue to something, but what it is, we need to keep attending to. And finally, after working in the clinic for a number of years, I turned to Schopenhauer. Schopenhauer says, if the immediate and direct purpose of our life is not suffering, then our existence is the most ill-adapted to its purpose in the world. I'm sorry, but that's what it seems sometimes. You come home at night and you want a couple of drinks after seeing 10 patients and none of them are getting better, and you know, it just seems really, really bad. Okay. Let's see where we go from there. That was a high point, by the way. After this, we're getting in. So I guess where we go from there is that studying disease in general from an evolutionary viewpoint, I think actually has turned out to be extremely productive for trying to understand mental disorders. And it helps, I think, the theme I strike with people when I'm talking about evolution and psychiatry is that if you really want to have a medical model for psychiatry, you need to use the same kind of medical framework that regular doctors use, which is not just molecules. Regular doctors know what the heart is for. They know what the gallbladder is for and how it works. They know how body temperature is regulated. They know how blood pressure is regulated. They know how the body grows and why reproduction starts at a certain age, or at least how it starts at a certain age. We don't have that kind of infrastructure, knowledge-wise, for understanding normal behavior. And a lot of you have this knowledge ready to share and trying to get it across to students who are going to grow up to be doctors, or better yet, to doctors themselves, is a great and huge challenge. So when I started working with George Williams, we started working on aging, and I want to tell you what we did for our first 6 months. We had long conversations about how does natural selection shape breast cancer? What's the selective advantage of atherosclerosis? Why is there acne? Why is there hemorrhoids? Why? We had these long conversations about every disease, trying to figure out how natural selection had shaped that disease. And finally, we turned to each other one night over drinks and said, wait, natural selection doesn't shape disease. Diseases are things some people get and other people don't. Natural selection explains things that we all share. We have the wrong focus completely. We've got to focus on traits we all share and why they're vulnerable to disease. And that was what made evolutionary medicine interesting and productive. This leaves me very sympathetic to my students who, even after my first month or two of teaching them, keep coming up to me and saying, yeah, I think the evolutionary explanation for bipolar disease is, I say, stop. And they say, oh yeah, we're not supposed to explain diseases, we're supposed to explain why we're vulnerable to diseases. Or people say, I've got an evolutionary explanation for eating disorders that gives an advantage by, no. If it gave that much of an advantage, everybody would have it, you know? If you want to talk about things that only some people have from an evolutionary viewpoint, you can talk about human subpopulations and special evolutionary forces such as sickle cell, or you can talk about facultative adaptations that lead people in different environments to behave different ways. But don't start talking about the evolutionary advantages of epilepsy or something. It's just nonsense. Two kinds of explanation, proximate and evolutionary. That is the foundation for everything. We owe it really to Tinbergen more than anybody else. And this offers a shift in perspective. I mean, my medical education was entirely from a mechanics perspective. That is, how does it work? What made it go wrong? How can you fix it? All of this applies all the way from molecules to nerves to brains to behavior. It's still a mechanics perspective. The plea is to change to an engineer's perspective, which is just right for Oakland County. Because right here we have some of the world's best automotive engineers, and they actually can help us teach, thinking in engineering terms about why things are vulnerable. My poor little BMW that I bought in Germany 8 years ago lost its air conditioning in Arizona. Let me tell you, you do not want a BMW or any car without air conditioning. I took it to the local Firestone guy, and he says, yeah, it's out of Freon. You want me to put some more in? I said, well, sure. And he put some more in. Guess what happened after a few weeks? The atmosphere of the whole world was a little bit worse, and I was out a few $100, and my car was still very hot. So then I took it to another guy, and he said, oh yeah, they all do that. They all do that? He said, oh yeah, they all leak after a while. Interesting. How much will it cost me to fix it? A couple of grand? We got to take, whoa, I don't know if I want to do that. And take it to another guy. And he says, you know what? There's a good reason why these things leak. It turns out that they changed the kind of Freon they put in a few years ago because of environmental standards, but they didn't change the condenser unit, and it wasn't up to the corrosion that was induced by that, so that's why they all go bad. Do you notice the completely different levels of sophistication we're doing here? One is a plain old mechanic's view, the other is a mechanic who knows the machine, and the third is a mechanic who's kind of thinking in historical terms about the mismatch between the condenser in that car and the stuff you put into it and why they all go bad. This is what we're doing in evolutionary medicine. We're trying to get people to think like engineers about why they all go bad, from description to explanation. And here's the mystery. If natural selection is so great, why do our bodies have all these flaws? And they really do. You've had your wisdom teeth pulled probably, and that's bad enough. Some of you have given birth to children. I mean, that canal is just too narrow, right? It's just ridiculous. We all have a blind spot in the back of our eye, which is stupid because you've got to have a steady jiggle in your eye to get a full image. It's just not a good design. And then, how many of us have back pain? You think you have back pain? We all have back pain. It's just the faulty design, and then there are hemorrhoids, and there's all these things. Why aren't we better? Gradually, this has developed a whole series of tools that I think are useful to anyone who tries to help people with mental disorders. The first is Tinbergen's 4 questions. The second is 6 reasons for why we're vulnerable. Third is understanding how emotions are useful in certain situations instead of talking about functions for emotions. Noting that emotions are especially those involved in goal pursuit, and I'm afraid this is domain general, not domain specific, often excessive for 2 reasons. And I want to conclude with what I'm going to talk about tomorrow, which is how social selection explains a lot of the extraordinary prosociality in humans, making group selection not an appropriate explanation for these kinds of things. But social selection can explain our extraordinary prosociality, which explains why we're so vulnerable to so many problems with self-esteem, social anxiety, and all the rest. And finally, a little bit about cliff edge effects and explanations for why we're vulnerable to genetic diseases like schizophrenia. So I've been fascinated and mulled over Tinbergen's 4 questions for ages. I hope all of you are as enamored of them as I am. He wrote them 53 years ago to honor his mentor, Conrad Lorenz, who had turned the ripe old age of 60, I think maybe only 50. He was like a young man as far as I'm concerned. Of course, Tinbergen's paper completely eclipsed his mentor and lives on. And many of us recognized it 3 years ago on the 50th anniversary. This is something that I first put up on the web in 2002 after staring at these questions and saying, there's some connection between all of them. And you can't all see it, but let's see. Whoa, that's good. But they get organized, these Tinbergen's 4 questions. I mean, 2 of them are evolutionary questions about the phylogeny, the history of a trait, and the other is the adaptive significance of a trait. And 2 of them are proximate questions, one about development or ontogeny, and the other about how it works. And I wish I had known this going through medical school, because I had so many late night discussions arguing with people about, was it the function or what, we just didn't have this tool ready at hand. Once you do, you can realize you need answers to 4 different questions for a full explanation of anything in biology. But we're not to pathology yet. Next, we have to go to the reasons for why natural selection leaves us vulnerable. And you can do this many different ways. When I first started teaching, I taught my students 19 different reasons why natural selection would leave us vulnerable. But gradually, these 6 have really caught on quite broadly and proved useful to people. The first is, there's some things natural selection can't do. When I was in medical school and I said, hey, myopia makes no sense. It can be heritable, but why didn't natural selection eliminate the genes? My professor told me, Dr. Nesse, you have to get used to natural selection isn't all that great. It just can't fix everything. There are mutations. Have you ever heard of mutations? I said, I've heard of mutations, but if I was like this on the African savannah, I would be lying lunch. It seems very implausible to me. Second, mismatch. Make rounds in any modern hospital, and 1/2 of the patients you will see are there because of diseases they would not have had at that age if they were living in a natural environment. All of the complications of blood pressure, including stroke, the atherosclerosis, most of the breast cancer, all of the complications of drug use and tobacco use, all are products of modern environment, and all the obesity-related diseases. 3, pathogens evolve faster than we can. The amazing thing is not that we still get infections. The amazing thing is that some days go by when we're not infected with something or another. Every trait is a trade-off. If I had one thing I'd want every doctor to understand very, very deeply is that nothing in the body can be perfect, because everything could be a little more this way with advantages and disadvantages, and a little more this way with advantages and disadvantages. That kind of thinking is not natural for doctors. They think there's normal, and not thinking so much about the advantages and disadvantages. I talk about, so how much acid do you want in your stomach? And people say, less, I'd have fewer ulcers. Yes, but you're more likely to get tuberculosis and all kinds of other things that otherwise would be killed by the acid. This is the most disturbing one, and I still wrestle with it. Isn't it creepy to think that natural selection does not shape us for health or happiness or longevity? Any allele that increases reproduction is going to spread and take over, even if it makes all of us unhappy, conflicted, conflictual, nasty, and short-lived. I don't like that idea at all. But it's key to understanding a lot of aspects of human behavior and why we all have all of these desires that we can't satisfy a lot of times, or that get us in trouble if we do try to satisfy them. You know what I'm talking about, right? Here's a question. What proportion of mental disorders are due to sex and reproductive conflicts? I once did a consecutive series of 40 patients, and it was 20 of them, where it was absolutely clear that someone was trying to find a mate and couldn't, or had a kid who was on drugs and couldn't get him off, or was in a marriage that wasn't satisfying but they couldn't leave. I mean, a whole proportion of the problems people face that are really serious are conflicts about reproduction. Freud was right about that in general, and David Buss has taken it to a whole new level. Last one is defenses, and this was a chapter I insisted on putting in. George wasn't so keen on it, but a whole lot of the problems people bring to the clinic are not diseases. They're the body's responses protecting us from diseases. So fever, pain, nausea, vomiting, diarrhea, anxiety, low mood, jealousy. Those are all capacities shaped by natural selection that are useful if they're expressed in the right circumstance. If they're expressed in the wrong circumstance, we call it an abnormality. Two giant classes of mental disorders. And this is something you won't see in the DSM. There's a bunch of them that are common that vary enormously across different cultures. The emotional disorders, depression is 10 times more common in the United States than it is in Taiwan. Anxiety disorders vary dramatically across different cultures. Alcohol use, dramatic differences. Huge cultural influences. Doesn't mean that they're caused by culture. There are evolutionary things going on there, but they're very different from these other disorders, such as schizophrenia, autism, bipolar disorder, and OCD. Interesting, all of those are near enough about 1% of the population. And although there is some interesting difference among cultures, it's kind of 1% most every place you go. We need different approaches to these based on the fundamentally different things that are going on. Again, defects are one kind of things people present, and defenses are others. Now we're getting to where the rubber really meets the road for me in terms of trying to use evolution to understand patients one by one. And this is really my next theme, is that I think this has been awfully useful to me in trying to understand patients one by one. Maybe I'll pause there for just a moment and tell you about driving into my driveway one night in Ann Arbor after a long day in clinic. I'd seen a lot of patients with panic disorder, and in the headlights, there's a rabbit who gets caught in the headlights. It was kind of late. And he just sits there, frozen. And I thought, that's interesting. My panic patients never do that. That's a fight-flight response, but a useful kind of thing. I went back to the clinic the next day. I'd been seeing panic patients then for about 12 years. And I said to my first patient, by the way, do you ever feel a moment of freezing? Oh, yeah. Every time I have a panic attack come out, I just feel like I might never be able to move again. I said, whoa, this theory stuff can actually get me to ask new questions that are quite useful. I was treating lots of panic patients at that point, and I think this is the single most practical implication of all of the things I've done. I previously had told my panic patients, don't worry, it's not your heart, it's not your brain, it's a mental illness caused by your brain, which is causing panic attacks, which is extra activity in your adrenergic system. So don't worry about it, and we'll give you behavior therapy and drugs, and it'll take care of it. And about half of my patients would say, thanks, Dr. Nesse. Do you know of a good cardiologist I could check with just to be sure? I couldn't convince them. And they went off for all kinds of other tests. Some even got, invasive cardiac tests, squirting dye on their arteries to see. Age 20, they got these kinds of tests. But then I shifted, And I started giving a whole new explanation. I started saying, you know what, these symptoms you're having, the shortness of breath is useful if you're about to run away from something. The sweating is good so you can cool your body and so you're slippery. The pounding heart rate gives your muscles, your tightness in your muscles and trembling, that's useful too. The flushing probably isn't useful, it's probably a side effect of that thing. And you're feeling like, I've just got to get out of here no matter what. It's exactly the feeling you want when some predator is just about to get you. However, for you, it's a false alarm in that system. Panic attacks are not useful in Kroger, no matter what they're charging you. It's okay. And lo and behold, most of my patients said, oh, that makes sense. And a fair proportion, about a quarter of them, would say, you know, now that I know it's not my heart or epilepsy or something else, that makes perfect sense. I'm just not going to pay any attention to it. And that was it. The rest needed big-time treatment. But talk about a practical intervention just based on explaining things based on science to people. Then there were other cases. I saw a lot of children, and sometimes you saw families where one child in the family was mistreated. And due to my evolutionary perspective, I was starting to ask new questions. And I remember vividly one family I was called in to consult on, and I saw the father, and I saw the mother, and I saw the kids, and the rest. And it just seemed like there was something funny going on. And so finally, I talked to the father alone, and I said, you know what, you have a different feeling about this kid? He says, yeah, I always have, I don't know why. I say, well, are you really sure it's your kid? And he got really quiet, and he said, I don't want to talk about that. I mean, these are real things in real families. And, you know, talking to everybody about, you know, their cognitions and their anxiety and their depression, you got to try to figure out what's going on emotionally. And here's a more lighthearted one. I remember vividly the kid who came to see me, moved from California to the University of Michigan, halfway through his education. And he said he had a problem with his girlfriend. He had a great girlfriend. He said she was really attractive and sexy and smart and loved him very much, but she was going to leave him unless he could change. She said he had to come for treatment. I said, whoa, what's the problem? He said, I'm jealous. I can't help it. I'm just jealous, and I keep worrying about where she is and what she's doing. And I said, well, do you have any reason to be jealous? He said, no. Absolutely not. She loves me. We're going to get married. Why are you laughing already? Have you heard the story before? Or do you just know about California in the 80s? So we talked some more, and I said, you sure there's no reason? He said, no. But you got to help me because she's going to leave me unless I can quit. You know, I kind of follow her sometimes and stuff. I said, what do you see? Nothing. She goes to work, you know, and, well, a couple nights a week she stays with the other guy, but they're just friends. They're just friends? Yeah, she swears they've been friends for a long, long time, and if I don't understand her need to have other friends, I can just leave her. I said, you know what? We have to have a talk. And, this is kind of tragic, isn't it? And then there's the 60s. I mean, I grew up in the 60s. We all thought that we could form communes, right? And we were all going to share on the work equally. Even that part didn't work. But a lot of people thought we're all going to have sex with each other and it'll be mellow because we don't do that old-fashioned jealousy kind of stuff. How many of those communes are left around exactly? Like 0. There were a few religious ones that have persisted with deep religious faith. But this is just not compatible with human nature. Talk about fundamental misunderstandings of human nature that have big implications for people's lives and how they live their lives and what they do. Let's go on with defenses and emotions for a little bit. I think the biggest impact of evolutionary thinking for psychiatry and psychology is trying to understand emotions. I got very frustrated, and in 1988 I decided enough of treating emotional disorders without knowing what emotions are, and I set aside the better part of a year to read everything I could about emotions. And at the end of that year, I almost gave up. It was a mess. There wasn't anything there. And finally I read this Business by William James. Did you ever read what William James said about emotions? William James said, as for reading the literature on the emotions, I'd as lief describe rocks on a New Hampshire farm as ever read them again. They give one no center, no purpose, no direction or frame of reference. And I thought, okay, if William James can be confused, I can be confused too. Is there something in here that evolution has to offer? I think it has a lot to offer, actually. We have to first figure out what emotions are. And we now can recognize emotions as really specialized modes of operation the organism goes into in response to situations that have recurred over evolutionary time that influence fitness. And organisms that go into that special mode in that situation get a selective advantage. Somebody with a lion breathing on them who says, "Oh, I'm in awe of you, kitty," not the right emotion, won't work. Someone whose lover touches them gently on the shoulder and looks into their eyes and says, "Ah!" That's not good for your reproductive success either. You got to have the right emotion in the right place. A lot of people study emotions and think they're good emotions and bad emotions. No. They're emotions that are useful in certain circumstances. And there's a lot of work on evolution of the emotions that posits functions for emotions. I think that's a mistake. Most emotions have multiple functions that are overlapping with other emotions. What we should be asking is the evolutionary question, in what situation has this suite of changes given selective advantages and how? Disadvantages too. So this is the diagram that I drew kind of willy-nilly, and it's caught on quite a lot actually because it shows why emotions research has been so problematic. The history of emotions research is an attempt to figure out whether dimensional approaches are right or whether there are a certain number of basic emotions. Neither of those is really compatible with the proper evolutionary view of specialized states that have all emerged from other somewhat specialized states to make overlapping clouds of responses, each of which corresponds to a somewhat different but often overlapping situation. Our human minds are desperate for nice clear categories and nice specific functions for each one. Sorry, we're doing evolution here, and evolution doesn't give us that kind of simplicity. So in what situation is the emotion useful is the question. And I'm going to provoke Jerry Wakefield here for a longer discussion he and I will have later. I think we'd all agree that threat of loss provokes anxiety, and those symptoms help you prevent the loss. This is pretty easy to understand. Loss itself, once it happens, I think causes sadness, and loss happens often enough of all different kinds that a specialized response to try to get what you lost or replace it or wait, or there's a lot of different things you do after a loss, and they all have to do with kinds of sadness. They are somewhat specialized for the domain in which you have the loss. A loss of a partner is different from a loss of money, is different from a loss of health, but they all have to do with loss and sadness, and for most of them, you lose it and you get over it. It's quite different, however, when your efforts are failing. If you're in the midst of trying to do something and you're not making it, then low mood evolves, or low mood emerges, in order to, and now I'm going to talk about the function of low mood. I don't mean to say that. In the situation of pursuing a goal you're not making progress towards, the suite of low mood changes tend to be useful. And notice I said tend to be, because these things I don't think are all that sophisticated. They're kind of crude mechanisms going on here. They're not perfectly attuned to every kind of situation, especially not modern situations. And then finally we get to many situations causing depression. It seems pretty clear to me that this suite of things can be set off by infection, it can be set off by losing a hierarchy battle, it can be set off by pursuing an unreachable goal. There are a lot of different things. We want things to be simple. We want to find the function or the situation. I don't think that's right. Many of you have heard the smoke detector principle. This is one of the simple ideas that I find to be a very useful tool for understanding a lot of why there's so much suffering in the world emotionally, and the fact that most of it is not necessary. The general idea is that false alarms in systems are normal if the alarm is cheap, but failing to have an alarm is expensive, such as you hear a noise behind a rock, is it a lion or a monkey? If there's a 1 in 1,000 chance it's a lion, you better hightail it out of there, even though this means that 999 times out of 1,000 it's a false alarm. This too is enormously helpful to my patients. Once I could explain to my patients that, hey, false alarms in this system are perfectly normal because getting eaten by a predator greatly decreases your fitness. And they said, oh, that makes sense. And that made them tolerate their own false alarms in this system much better than previously. This applies very generally to medicine, and our next hire at Arizona State may well be someone who helps us understand how natural selection essentially manipulates the terms of signal detection theory to regulate the expression of defenses, and we're particularly interested in inflammation and immune responses because of the huge epidemic of autoimmune diseases that we're having, which we think can be, in part, have an evolutionary explanation based on how natural selection shapes the mechanisms that regulate these things. Huge implications for psychopharmacology. Radio guys often say, oh, Dr. Nesse, you think depression is useful, so we shouldn't treat depression, right? Say, no, I agreed to talk with you on the condition you wouldn't say that stupidness. Actually, the whole point of this is that a lot of the problems we see in psychiatry, just like in the rest of medicine, are normal responses that aren't useful. So just like you can block pain, fever, nausea, vomiting, and all the rest safely most of the time, you can usually block, all kinds of negative emotions safely most of the time. But wouldn't it be nice if doctors and anybody who's treating mental disorders actually knew what the utility of these things was before they willy-nilly go blocking them without thinking? And then again, emotions are not for us. Our emotions are to get us to do things that are good for our genes. And Lord knows Freud was right about one thing. We are really peculiar about our interest in sex. And we care not only who we have sex with, but we care who has sex with us. People even care who other people are having sex with, especially in North Carolina. It's really, really bad. And we care a lot about what happens to our kids. And I must say, something that I keep being amazed by, and I hope you'll share it with me. I went through a very bad period of being very cynical as a result of selfish gene kind of thinking, which was kind of naive, but in retrospect, shared by many people. I think reading The Selfish Gene has traumatic effects on many people. I wrote a chapter to try to immunize my students, and your students might like it too. They allowed me to use the long title. It's in the book, Selfish Gene at 30. Actually, they changed the title of the book. It's not The Selfish Gene at 30. When they published it, it came out as Richard Dawkins, the Man Who Changed the Way We Think. Oh well. The title of the chapter is Why So Many People with Selfish Genes Are Generally Pretty Nice, Except for Their Hatred of the Selfish Gene. And in that book, I talk about the many different psychological machinations people use to cope with the fact of these whole systems being shaped for the benefit of our genes, not us. It's very disturbing. And now, in what situation is low mood useful? Again, we've talked about that just a little bit, but again, not just one situation. I think the work by Gilbert and a lot of other people talking about loss of position in a hierarchy is important. Yes, that can absolutely do it. A subtype of low mood, I'd suspect. Pursuing an unreachable goal, I started asking my patients after coming up with this, and I started saying, we've talked for an hour, but is there something really big you're trying to do that you just feel very important to you, but you're not making any progress and you can't give it up? And a lot of people said, no, I already told you, doctor. But some of the times the person would pause and say, actually, my wife drinks 3 quarts of Coke every day, and she's 300 pounds, and I don't want to have sex with her anymore. She wants to have sex with me, and I don't like that. And I don't want to divorce her, but I don't want to stay with her, and I don't know what to do. And that's a poignant one. And then they see all these kids at the university who are like 3 or 4 years into a physics PhD, and they realize that they can probably finish it, but they're never going to get a job. So should they quit and admit to everybody in their family they're not going to become a physicist? And then there are the taxi cab poets. Do you have any idea how many people driving taxi cabs in Ann Arbor are really quite talented poets and wondering if their girlfriends will stay with them because they're not making any money? It's a real bad dilemma. If you want to be a poet, nobody's going to pay you for it. You got to make a living somehow. And there's time if you're driving a taxi. But these are unhappy people because they're pursuing a really important goal that's the center to their meaning in life. And it's not actually working. It's not just one little part of their life isn't working. The whole life isn't working. I call this the motivational structure of a person's life. And I've been teaching my residents to really attend very directly to the individual and what that individual is trying to do in life and how every component of it's working and how it's all working together. And over again, you figure out that for most emotional disorders, there's something pretty seriously wrong. Now, there are other people who have the same kind of screwed up life situation who are not having the same emotional reactions. It's not like this situation causes this. Huge variation in vulnerability to these negative emotions and in emotionality in general. So this is no one-size-fits-all. But if we really want to understand our patients, I think we've got to sit and talk with them for hours often, and it helps if you have an evolutionary perspective. You have a deeper understanding. Again, the situation that's perfect for creating depression is created very often, I think, by our universities. And I think our society in general may be more likely to create these situations than others because of the long-term goals people are pursuing. This is William Blake in Songs of Innocence and Experience. There's nothing new under the sun, really. Blake says, if any could desire what he is incapable of possessing, despair must be his eternal lot. And again, the radio announcer is liable to say to me, so Dr. Nesse, you advocate people just giving up, right? No, I don't. And let me tell you just how cautious I'm encouraging people to be about this. I told a doctor friend one time about this basic idea. He said, wow, that makes great sense. I'm going to start using that. And then I saw him again a year later. He says, you know what? There was this patient. I couldn't get better. I'd had her like on 5 antidepressants. She tried psychotherapy. Nothing was working. And finally, I just sat down and explained it to her. I said, what do you mean? He said, well, her whole goal in life had been to find a man. And she was 36 years old. And she was short. And she was kind of dumpy looking. And she wasn't just that interesting. So I finally told her, listen, you're devoting your whole life to finding a man. And you're kind of short. And you're not that good looking, and you're not that interesting, and this is probably not going to work. Isn't that awful? It probably was true. But I think it's so important for all of us to not do this stupidly. I think it really takes experience and understanding, and these are well-meaning, smart people doing this kind of thing, and I think it's so important to, try to do it in a thoughtful, kind way. This is work by Matt Keller. A lot of people have extended it further. He took the bold move in his thesis of asking if we should be talking about depression in general or if we should be talking about specific depression symptoms, more like the different symptoms of a cold, which have independent origins and independent functions in different situations. And he has quite good evidence, actually, that the symptoms that are caused by failed effort and those caused by social loss are really very different. Eiko Fried has been working with me in recent years, and we published a series of 8 papers now looking at individual depression symptoms, and each one of those papers shows how looking at individual symptoms gives you different predictive power than the overall sum score. Can we find the actual specific depression symptom scores on any of the NIH research projects? No. They tossed them all out. Oh my. But we're continuing to try to find sources. If anybody of you know of any databases that have individual scores we can look at, we think we can make very powerful predictions using individual scores. Let's see. I told you some of the things that I did that were really stupid because of an apparent evolutionary perspective. Let me just tell you a couple more while I'm embarrassing myself. How about this one? I was never trained to do sex therapy, but you see who you see, right? A nice couple comes in, and they seem to like each other pretty much. I didn't see any big problems in the relationship. They just weren't interested. And it was a time when we were all, excited about pheromones. And I had just done a study actually looking at whether using deodorant might change the matching of cycles in women who shared a dormitory room. So I was really quite into this. So I told my patients, you know what? Just stop using deodorant and see if that helps your sex life. It was well-meaning, but really stupid. This was just an amateur trying to be helpful. And I think, you do that, but we should try not to do that. We should all try to actually get trained in the specific things where we're offering people advice on. It wasn't as bad as the things I did before I had an evolutionary perspective. I spent a year with one patient trying to help this depressed patient get in touch with her. She had depression after loss of a loved one, a loss of a child. And I said, you know what? Analytic theory tells us that it's your unconscious anger towards your child who was drinking and doing drugs when he died that is causing your problem. So we need to get you in touch with your anger. I'm sorry, but there's still therapists doing this all around the world, trying to help get people in touch with their anger to get over their depression after grief. There's no scientific evidence whatsoever to support that. In our large grief study, we proved that the people who had the most grief were, guess what? The people who cared the most about their loved ones. The ones who had anger, many of them reported, you know what? I'm better now that they're gone. Thank you. So there are a lot of stupid things we don't have to do anymore, thanks to more sophisticated thinking. But I fear there are some we're still doing. Lastly, I think there are good ideas for research that come from evolutionary perspectives, and I could talk much more about OCD and schizophrenia and autism, all these more severe, more genetic disorders. The question here is why genes for these devastating disorders that cut your reproductive success by half show up. There's a lot of speculation out there that somehow either the schizophrenia itself or relatives have some selective advantage. Maybe they're creative, maybe something. You know what? If you have half as many children as other people, your genes are going to go away. We've now run the entire genome for schizophrenia, and we have identified 30, 40 possible alleles that are related to schizophrenia. And the ones with the largest effects might influence 1% of the variants. There are no genes that are common of large effect that influence the prevalence of schizophrenia. The idea that we all thought 15 years ago, we're going to find the genes. They're not there. We need a different approach. The big approach now is to find out which combination of 3 genes is doing it. I think this is tacit creationism. This is based on the idea that natural selection has shaped some system, kind of like a computer program would shape it. I don't think that's right at all. My best guess is what I call cliff edge effects. This is based on David Lack, the famous ornithologist's work, where he took eggs from one bird's nest and put it in another bird's nest. His question was, why don't birds lay an extra leg or two? They can have extra reproductive success. And as he did put eggs from one nest into another nest, they did fledge one more young. If you put 2 in, they fledge about the same as one with 6 eggs. If they put 3 in, they all might die. So this is a cliff edge where as you push further and further along that cliff edge, you get more and more reproductive success until the whole thing collapses. I realize it's metaphorical, but I think a number of these disorders, we're not going to find specific genetic causes or specific brain abnormalities. We need to start thinking about the systems that are going awry and whether or not natural selection might have pushed some trait close to some cliff edge so that some individuals fall off. They're in that 1%. And the rest of them get a selective advantage from being that close to the cliff edge. The other example of this is the cannon bone of a horse. If you breed horses for speed, what you get is a cannon bone that's longer and longer and thinner and lighter and more vulnerable to breaking. Most really fast horses don't break their cannon bones. It's not like a genes for light cannon bones makes it break, but it makes them more vulnerable. And something like that, I think, may be going on for some of our mental disorders, but it'll take some of you to take it further. I think so far it's just a metaphor. This is more work by Matt Keller looking at the proportion of genes explained. All of these genes, all of these alleles are on the same line, and they all account for the same proportion of variation. And that proportion is 0.04% of the variation, which is to say nothing. The question is, why aren't there any alleles there? I'm pretty sure the answer is that they've been knocked out by natural selection. But a lot of the people who are doing work on schizophrenia are not thinking in these evolutionary terms. So wrapping up, I think there are 6 reasons for vulnerability, and I hope that everybody could take these away and use them to try to understand not why natural selection shapes diseases, but why natural selection leaves us vulnerable to mental disorders. Constraints on what natural selection can do, things happen. Mismatch, yep, a lot of disorders. Eating disorders weren't there much at all 50 years ago, hardly at all 100 years ago. Coevolution, not as relevant, but infectious disease is relevant to our business. Trade-offs, everything's a trade-off. Selection is not for health, much more to say about that another time. And then emotions, negative emotions are useful defenses, regulated in ways that makes them expressed often when they're not actually needed. So big conclusions. I do think evolution is a crucial basic science for medicine. We should somehow try to get it to everybody, but boy, do we have a lot of work to do. And to do it, I think we're going to need to be both cautious and modest, because psychiatrists are dead set on trying to be as scientific as possible and like the rest of medicine. And if we go around saying, we've got the new solution to everything, they'll run as fast as if it was primal scream therapy or something. They just won't want anything to do with it. I think our only hope is to be very cautious and modest about what we have to offer. And in fact, I don't think we have dramatic, huge things to offer. I don't think we have new treatments. What we have is a framework and a foundation for people understanding normal behavior, which helps some as you're trying to understand patients and trying to figure out new research projects. And I'll leave you with where I have come out after my kind of cynical, sad phase when the selfish gene idea interfered with my thinking. And that is, actually, there are people who have whole days when they're kind of happy and healthy. And there are people who have relationships that are actually pretty good and loving and stable. Isn't it fabulous? It didn't have to be this way. And in fact, you wouldn't necessarily expect it to be this way from a straightforward, crude evolutionary view. And I'll talk a little bit more about that tomorrow. But I think we all can be so grateful that somehow or another we've ended up as a species where we're pretty good some of the time. Thank you very much. I'm going to have a bite of my dessert while you're thinking of your first question. It's in the freezer. Oh, well. I'll assure you, we're not going to have very long for questions because it's late. And some of you have flown over ponds. This man, for him, it's 3 o'clock in the morning. He's still awake. I'm very impressed, Martin. Good job. Best please.
Have you run into any situation where giving a patient a logical explanation for what's going on kind of backfired, or you couldn't get them to understand it correctly, so they kind of took a turn for the worse or something like that?
When I was doing psychoanalytic psychotherapy, which I did quite a lot of, my supervisors kept saying, Nesse, are you ever going to get the idea what a premature interpretation is? Because I kept kind of figuring out what was going on. I'd say to the guy who said, all the people in my neighborhood are doing this stuff, and I joined the church, and we're going around getting rid of the pornography in all the stands. And I'd say to him, gosh, anytime you want to have sex with somebody you're not supposed to? And he'd go, oh, what? That's called a premature interpretation. It's right, but it's absolutely useless or worse. So I think that kind of principle from psychoanalysis is equally true. In fact, one of the deep things I learned from psychoanalysis and writing some papers about it is that logical rationality, objectivity, probably does not maximize your fitness. Bob Travers has talked about this in the introduction to Selfish Gene as a way of manipulating other people better by sneaking around and pursuing it. Yeah, I think that's probably true. But it's also true that in general, I think being accurately aware of everything you're doing consciously makes it very hard to go forward with your life or have friends, because nobody's perfect. People who are very astutely aware of every slight that their friend, they can't have friends very long. Much better to just let it go. Psychoanalysts didn't like that idea very much, by the way. One or two more.
Your cliff edge idea, do you have any sort of ideas about what traits are on that cliff edge?
No. And it might not be a specific cognitive trait. The idea of brain pruning. It turns out that the mechanism that causes Alzheimer's disease turns out to be the same in terms of the inflammatories. It's beta amyloid and the cytochrome C that knocks out neurons and prunes them at the time of adolescence. The same basic mechanism is working in later life. And it might be that over-pruning takes things beyond the point of optimality to something else. I don't have any idea really what it is. We should look very broadly at the possibilities. Yes?
In thinking about vulnerability to mental disorders, which of the 6 factors do you think are most susceptible to successful intervention in terms of reducing, alleviating suffering?
So to her question, is your question about which ones make us most vulnerable or which ones we can do the most about?
Which do you think are most susceptible to intervention?
So here's a practical person asking the right question. Right. So using these 6 things, which ones can you actually do something about? Certainly if something is a product of a modern environment, then if you can change that environment, you can do something about it. However, for the epidemic of eating disorders, you can't turn off people's televisions and change the kind of sexual competition that's going on all around them. So it's very hard to do. You can change what people eat, and you can change the amount of omega-6s and omega-3s they take in. It seems quite likely that some depression is a product of increased inflammation because of omega-6s in our diet versus omega-3s. There are that kind of thing that you can do. But the one about our genes making brains that are good for their success and not our success, you can't do anything about it. But doesn't it give you just a little bit of a sense of humor about the human plight, you know? I mean, sometimes when I'm feeling low, I think, you know what? It's kind of like modern Buddhism light or something. You know, you've got all these desires, you know, we're not going to satisfy them. We're made to feel bad about it, but what the hell? You know, we're not, it's just, it helps a little, only a little. I mean, that's like trying to decide not to eat so much when you're trying to diet, you know. But I think it helps a little bit. What about some of the others? Defenses, I mean, that I think is very practical. Once people recognize, and I find for so many of my patients, they've been going around thinking, oh my God, I have anxiety, there's something wrong with me, I'm a defective person. I should try to be more bold. And telling them, you know what? You have social anxiety, you're probably one of those more sensitive people that people like. People who don't have social anxiety are really a social menace. You should feel a little bit appreciative of your special sensitivity because it's really very valuable. And they kind of go, oh, gosh, actually, now that you mention it, you know. And likewise for depression. I mean, sometimes depression is just plain a bad abnormality and you got to convince somebody to take their drugs and shut up until they get better. But sometimes talking to someone about the meaning of their mood, it gives them a sense that it's not just depression taking over their lives, it's their life, and the depression is meaningful even if they can't fix it by just thinking about it. And it helps them to, instead of just ruminating about things, to think about their problem and whether it actually is solvable. And if it isn't solvable, I mean, another quick case is a cleaning lady from the university who came to see us one time. And she was very, very depressed, and how is it going? I like living alone. I really love my church. I'm very close to my family. And you know, do you have any kids? You have my daughter. She's not doing so well. But she's not doing so well? Well, actually, she's on drugs, but I can't help her. How old is your daughter? Oh, she's 20. So what was life like for you when you were young? And she starts crying. And she says, well, actually, when I was in high school, I moved in with a drug dealer because it was a cool thing to do. And he was addicted, and I was addicted, and he went to prison. And I had to bring up my daughter by myself. And I vowed whatever happened, she would never get on drugs. And I talked to her about this. I devoted her my entire life. And she graduated from high school barely and moved in with a local dealer. And now she won't talk with me. What should I do, doctor? You know, the problems people have that cause depression are not readily solvable, and it would have solved them. But identifying them allows you, I think, not to say, oh, quit worrying about that. It allows you to say, gosh, I can understand why you can't give up on pursuing that. But could we talk? And now we're back to Leif and his work on behavioral therapy, not just simplistic behavioral therapy, but talking about, gosh, is this really helping your daughter, you being depressed and all this kind of stuff? Or would a different model you could offer for her be better for her? And the idea that a different model of going out and doing things instead of moping in a room all the time was better for her daughter actually helped her move on very dramatically. So I think these are practically useful, but you got to kind of custom craft what you're doing for every individual. And that's hard. I think we should take one more and then let people go home, if there even is one more. In that case, it's late.
Thank you again, Randy.
Thank you.